next topic is anesthetic implication on scoliosis. I welcome Dr. Balavenkatasubramanian back onto stage.
So, back again, and now I'm going to speak about some of the important considerations in pediatric patients coming for reconstructive spine surgery. I'm very happy to share that our unit is one of the recognized unit for spine procedures. Last year we have done 3,400 major spine surgeries, 14 dedicated spine surgeons, and 3 years ago we moved into the top 15 institutions doing spine surgery in the world, called as the ISOC group. So of the 3,300 surgeries we have done, pediatric scoliosis contributes to about 12% of our surgeries. So what I'm going to share today is the challenges that we face in scoliosis. So some of the pictures are pediatric, but some of them I've used the adult pictures to emphasize the points. Generally, the scoliosis is because it is either idiopathic majority of the time, sometimes it's congenital, paralytic, associated with neurofibromatosis, and sometimes it's mesenchymal. As you all know, scoliosis means it's lateral curvature of the spine. Like any other anesthesia, in scoliosis surgery, the preoperative evaluation is extremely important, and the respiratory system and the cardiovascular system are extremely crucial. So when you do a pre-anesthetic evaluation of your patient who comes in, the location where the curve has deformed is very important. For example, if it involves the cervical level, the first thing that goes into your mind is the difficulty in intubation. When it happens in the thoracic level, we are very concerned about the respiratory system, and the preoperative pulmonary function becomes extremely essential. You know, the scoliosis, fortunately, the cervical involvement is very less. Majority of them are thoracic, thoracolumbar, and pure lumbar. So thoracolumbar is very, very high. And also, you know, when you do with a pediatric scoliosis, if it is congenital in origin, that you know the development of the alveolar units are very crucial when this started, when the structural abnormality started. If it's present from the birth, both the chest wall cavity and the spine curvature, then the development of the alveolar units are highly impaired. And you know, the first 8 years in the life of a pediatric patient is essential for the development of the alveoli, where it multiplies into several units, millions of units, and this is restricted because whenever you have a thoracic involvement, where unfortunately several of the thoracic level scoliosis is not only a skeletal abnormality of the spine, but also of the chest wall, limiting the formation of good amount of alveolar units. Age of onset again is very important. It's divided into early onset. Early onset is divided into infantile if it's less than 4 years. If it's between 4 to 9, we call it as juvenile. And adolescent scoliosis, which is much more common, it starts at after 10 years. And I would want to confess, majority of our scoliosis surgery, the adolescent scoliosis, is from the state of Kerala. For some reason, I do not know, the patient population in Kerala have the most number of adolescent scoliosis. At the same point, I would wanted to confess that the malignant hypothermia, which we have seen, the first 5 reports that are seen in Indian literature, all the 5 patients belong to Kerala. So this is another thing which I would wanted to convey to you. Then adult scoliosis is above the age of 18 to 20 years, but of this, adolescent scoliosis is the most important one. And all of you as postgraduates would have read about Cobb's angle. It's very important as an anesthetist when you do a pre-anesthetic evaluation to note the Cobb's angle. Usually the surgeon asks for the surgery when it is more than 50 to 60 degrees. Less than that, if you do, it is mainly cosmetic, but usually 50 to 60 degrees, then the surgeon would ask for a surgical procedure. When it is more than 90 degrees, it's a word of caution to you that it's a significant correction that is to be done, and the intraoperative neurological injury to the spinal cord would be very high, intraoperative blood loss would be very high. These points have to be taken into consideration when you do the pre-anesthetic evaluation. Sometimes it's really severe and considerably deformed. The the etiology of many times, as I said, when it is congenital, it is associated with several other abnormalities, like what you see in this patient. You see there are other skeletal deformities. She also had a cataract, and when you deal with scoliosis pre-anesthetic evaluation, you definitely, when they're less than 4 years, you have to look for other associated abnormalities. And neurofibromatosis is associated with scoliosis. They pose a great challenge to you when a patient like this comes in. And also Marfan syndrome, you know that they're associated with endocardial cushion defects. So the pre-anesthetic evaluation of these patients become extremely vital to have a strategy. Number one, whether you need to take them immediately for surgery or you have to do prehabilitation, including correcting their using incentive spirometry. In children, it becomes very difficult to make them do respiratory exercises, but fortunately, the number of patients in the below the age of 4 years coming for surgery is very, very less. And the major challenges in the commonly seen scoliosis is the decreased chest wall compliance, decreased lung volume, and several of them, especially when the Cobb angle is more than 70 degrees and poor development of pulmonaries, pulmonary hypertension, hence echocardiogram and evaluation of the pulmonary pressures are very important because you also have to know the right ventricular functions in these patients. And in the cardiovascular system, the commonest abnormalities that we have noticed are mitral valve prolapse, associated cardiomyopathy, and there are several other possible congenital heart ailments which are present. Preoperative neurological assessment should be precisely done to note that whether there is an intraoperative aggravation of the neurology. Hence, this needs to be documented in the pre-anesthetic evaluation. So, when we see these patients in the pre-op, if they can understand, the best thing is to put them on incentive spirometry. Sometimes you might have to put them on bronchodilators, and there are units which still do the Stagnera wake-up test intraoperatively. So it becomes prudent that you explain to the child that during the surgery is going on, in between we would call you where the anesthesia is lightened, and then you call inside, ask them to move the toes. So several surgical spine units still use Stagnera wake-up test, and more so if it's a severe deformity where the chances of intraoperative neurological injury is very high. And post-op ventilation is yet another point which we need to discuss with the attendants. And if one of the cautions that I would wanted to mention is if it is more than 5 vertebral bodies involved, and an expected duration of surgery of more than 4 hours, and with the anticipated blood loss more than 1000 ml, then you might have to think in terms of ventilating this patient in the post-operative period. And also, several times they are associated with muscular dystrophies, like Duchenne muscular dystrophy is one condition where you see scoliosis. Invariably, you need to ventilate them electively for 24 to 48 hours to get the internal milieu back to normal. So all this has to be, counseling has to be done in the preoperative period when you deal with this patient. So ABG is a good idea to do to see the level of oxygenation. Pre-medication is highly individualized, but whenever you deal with the positions which is either lateral or prone, and you might think of using an anti-zygogogue, and whenever it is a possible cardiac abnormality present, you have to think of endocarditis prophylaxis. Sometimes, when it involves the cervical and the thoracic level, the extension is grossly limited, and then you might have to plan for an awake fiber optic intubation. And the intraoperative strategies, if it's a prolonged duration surgery with anticipated blood loss, if it's going to be high, it's a good idea always to rely on an invasive pressure monitor, because NIBP to take every 5 minutes for 6 hours or 5 hours, it's going to, number one, it's the reliability, and number two, the quickness with which you see, because whenever they do a periosteal stripping, suddenly there is a huge blood loss, and even before your pressures could be monitored by an NIBP, you'll see the pressures going very low. So it's a very good idea to go for an invasive pressure monitoring and continuous monitoring of SpO2. This is truly a challenge, especially with the arms by the side, and you put the probe inside, and many times it gets dislocated. So you need to secure your pulse oximeter appropriately. A single most important thing that you will do when you position the patient. End-tidal carbon dioxide, 100% important to monitor the temperature, especially when long segments are involved, they become very hypothermic. So it's very important to monitor the temperature, the core temperature. Then the electrocardiogram, the urine output to be monitored every hour very closely, and specialized monitoring. Now, when you do with highly critical cases, the best results can be obtained by using specialized monitoring. So we use routinely somatosensory evoked potentials and motor evoked potentials, and we go for an anesthesia which is purely intravenous. And we don't use inhalational agents because they interfere with MEP and SSEP. We don't use muscle relaxants. So even intubating dose is not given. So the minute it's an IV induction and then intubation, and you do your SSCP MEP, you connect everything before turning the patient prone, do the preliminary MEP SSCP, see the lag period. I'll just come to that. So the primary goal of the intraoperative neurological monitoring is to identify intraoperative neural insult. Majority of the time this happens after they have put the screws on either side, and when they're going to correct the bend, this is the time when the vascular insufficiency happens and the neurological deficit happens. So the anesthetist have to carefully monitor this particular phase when they're going to correct the bend that is present, and this produces ischemia to the cord, and suddenly you will see a loss of MEP. So this is very crucial, and it needs to be monitored. And intraoperative monitoring shows a lot of other things which I would really not want to enumerate, but the most important thing is to see sudden onset of neurological insufficiency. So in somatosensory evoked potential, it's slightly cumbersome. There are multiple electrodes that are involved. It just monitors the sensory pathway, and sometimes it's very difficult to interpret until otherwise you have a neurophysiologist. So we have a trained neurophysiologist to do this intraoperatively. MEP is more easy, more reliable. It's basically a high voltage. Transcranially you stimulate the motor cortex and you measure you put electrodes into the various muscles, and you see, I'll show you the waveform. And here the motor pathways are analyzed. It is much easier to interpret than SECP. So this is how we put transcranially. If you see, the electrodes are inserted here. This is for D12 level, this is for L23 level, and this is for L5 level. And just I would wanted to show that it's very important when you use an MEP, especially when you don't use a muscle relaxant, it is truly important to secure the patient very well like this, because the jerk that is produced, and also the way you fix the tube and the eyes, it's very important when you use MEP, because a sudden jerk that happens, then there can be, the patient even can sometimes move away from the bolster that you kept inside. So it is very important to use proper strapping of the patient. This is how exactly we use a Medtronic monitor, and this is how the screen would look, and you'll have to closely monitor, and it's best to have a neurophysiologist to do it for you. Along with this, we also use computer-assisted navigation procedure, which has made it much more easier for the surgeon to put exactly, because sometimes the pedicle is very small, and to go exactly into the pedicle, this is called the Brain Lab. This is the one which we have. So this is called the computer-assisted navigation, and this is connected to it. This is a 3D C-arm. So we also currently have an intraoperative CT. So an intraoperative CT, a computer-assisted navigation with a 3D C-arm makes the best combination for the surgeon to do his surgery precisely and meticulously and give excellent results. And as an anesthetist, it's important to work on the position of the patient. It is truly the key, and it's very important when you position the two bolsters to make sure that the diaphragm moves well. This is the simple, single, important point that you need to do when you position the patient to prevent intraoperative bleeding. If you make a mistake here, you're going to produce profound amount of bleeding. There are several frames available, rental horn frame, bolsters, but I would wanted to emphasize when you put the patient prone, this is one, especially in pediatric scoliosis, especially when the cervical and thoracic level are involved. After you position the patient prone, very, very important to see the bilateral air entry is equal or not. Several times you see the tube migrating because of the abnormalities present here. When the head gets flexed or slightly extended, the tube goes endobronchial and it becomes a one-lung ventilation and hypoxia persists. So just before you allow the surgeon to go ahead with the surgery, the minute you position prone, it's important to check for the air entry on both the sides after you have put the adequate position, either its extension or mild flexion of the neck. You also have to give a lot of importance to padding of the eye. The next complication which we notice in long duration surgery is swelling of the lips, and then they really become big. Sometimes we have seen that the lips undergo ulceration later, and believe me, if it's a small young child who came for a cosmetic correction and you give a very bizarre lip later on. So there's a small point. So what we have started doing is we use a lot of soft pads to see and then put a plaster over that so that the lips don't swell. After we started doing this, the last 2 years we don't have lip swelling, and you need to make sure that you maintain the angle of the neck with the shoulder. It should not be adducted or abducted to prevent neuropraxia of the brachial plexus. Then the ulnar, axillary, the lateral cutaneous nerve, the soft tissues, all this has to be taken care of. Neck position has to be taken care of to see that there is good cerebral blood flow, venous drainage happening. Abdominal pressure is again something which I just put some pictures to show how it's important to fix it. We use plasters, we use also the knots and the thread, so that double protection to see that the tube doesn't get accidental extubation is very important. And the free abdomen is truly important, because if you don't do this particular thing, then there is diaphragmatic splinting, a positive pressure, increased intra-abdominal pressure, and you see that the epidural venous veins get engorged and a lot of blood loss happens. So sometimes we have to give some big positions like this, and it is too crucial that you will look into every parts that has to be protected. Blood loss is the challenge in the intraoperative period, and it directly relates to the duration of the surgery, number of segments, vascularity of the region, and decortication. So one important point that you need to ask the surgeon before is, are you going to decorticate? The minute they say decorticate, it's definitely a liter or more of blood loss that happens. So for an average scoliosis correction, the loss is anywhere between 1000 to 3000 ml. The next thing which you need to think is the optic neuropathy, anterior ischemic optic neuropathy and posterior ischemic optic neuropathy. Majority of the time, it is not the direct pressure on the eyeball which results in optic neuropathy. It is because of hypoperfusion of the retina and also a low hemoglobin because of sudden blood loss. Two things, hypotension and low hemoglobin, intraoperatively precipitates posterior ischemic optic neuropathy, where after extubation you will see the child is blind. So this is something very important, and this calls for an invasive pressure monitoring to keep the perfusion pressures and to see the hemoglobin periodically to make sure that you maintain a hematocrit of around 25 to 30 in the intraoperative period. So this is something which is very, very important. Local vasoconstrictors are used in the skin to decrease the blood loss, and the surgical techniques, the surgeons have perfected a lot of techniques, especially subperiosteal dissection is one simple thing which has decreased in blood loss. Some units use hydrogen peroxide, we don't do it, but centers using hydrogen peroxide have to be careful of oxygen venous embolism which is happening. Bone wax, gelatin and surgical gels have decreased the intraoperative blood loss. Hypertensive anesthesia to be done with caution, but a mean arterial pressure of 60 I think is something very safe and which could be used in all your scoliosis surgery. And especially when you use SSCP, MEP, even you can go down to 55, but closely monitor the neurology of the patient. When we use auto transfusion, we also have a facility to do auto transfusion. One of the important things that I would wanted to say, when you do auto transfusion of more than 1 liter in a simple sitting, it has also been found to produce severe inflammatory reaction in the post-operative period. This is a word of caution when we use the auto transfusion. A word about preoperative autologous donation, especially when you do slightly younger, elder children, like about 12 to 14 years. If the hemoglobin is good, you can think of preoperative autologous donation. So this I spoke about cell saver. If the pre-op hemoglobin is low, you have to think of using preoperative erythropoietin in this patient to build up the hemoglobin level. The anesthetic technique we use is, as I said, is total intravenous anesthesia, no relaxant. And when we do anterior instrumentation, you need to have a chest tube inside. And now we started using thoracic paravertebral block and erector spinal block, and excellent post-operative pain relief when you do this. And for posterior surgeries also, we do bilateral erector spinal block. And believe me, this is a single most important intervention which has changed the post-operative requirement of analgesics, and the VAS score remains less than 3 in the immediate post-operative period for as high as 14 to 16 hours, which I strongly recommend. That we are moving into an era of regional anesthesia where you make a huge difference in major surgeries. Intraoperative hypothermia has to be avoided, and the post-operative concerns are mainly extubation protocol. Second thing is blood loss that needs to be compensated. Post-op pulmonary exercises, many of them develop adynamic ileus. So starting oral feeds has to be done with, we have to be very careful. Then hyponatremia is something which you see very often in major spine surgeries, and ambulation has to start early, and for that you need to have excellent pain control. So as I said, we used several things, but currently the simplest of and the best thing is erector spinae. The last slide which I want to show is sometimes children come with such severe deformities that they have very poor pulmonary function tests. This is a patient with neurofibromatosis with severe deformity, and when they come for a surgery, they're absolutely unfit for a general anesthetic procedure. So what we do is we put on a halopelvic distractor. They are on this for 6 months. The patient keeps on rotating it, and slowly the chest wall compliance become better. And after 6 months of putting on halopelvic distractor and good rehabilitation, we take them for a definitive surgical procedure. And anesthesia for spine surgery, especially for pediatrics, is extremely challenging but truly rewarding. Thank you very much for your patient hearing.
Thank you, Bala. Wish we had more time to see all your pictures, but thank you very much. We'll go on to the next one.